let's go to the next one. So, the history. Just one additional point to what other colleagues have already said. Dr. Ahmed this morning and also Dr. Serge now. You know, the interaction of human health and environment is very, very old. It's much more than one century ago. And in terms of treatment, you know that the main treatment for tuberculosis was the sunlight. The older doctor among you may know that. When before the antibiotic era, tuberculosis was treated with sunlight, with good food and sunlight. And in the memory of our grandfather and ancestors, having good health always was living in harmony with the environment, with the animals and with the plant. So it's not something new. Now is getting a lot of emphasis, especially in the past few years, because of the concern related to health security. Because the world realized that epidemic happened, pandemic happened, they are going to happen again, and there is no segregation in the natural for the origin of pathogens. Pathogens can come from the animal world, can also come from the environment. So addressing health with a One Health approach is absolutely necessary to protect the humans, beside all the other considerations, economic and environmental, etc. Next. No, we are already there. The global framework. Dr. Serge explained a lot of things about the global framework. I am in WHO now. I am very proud to say that WHO has the lead in this quadripartite agreement. And this is a very important step, which is not a new program. It's a commitment for collaboration. It's not inventing something new. But what the World Health Organization is doing has to link with what the Food and Agriculture Organization is doing, the environmental program, and also the Organization for Animal Health. So creating this synergy is the commitment. The Memorandum of Understanding is about creating synergies. And also together helping the countries in going that way, also including rising resources for that, for implementing the One Health approach. So there is a joint action plan and an implementation guidance. Let's go to the next slide. And what already Dr. Serge showed, there was very recently, last week, the second meeting of the quadripartite agreement in Nairobi. And this is a statement by Dr. Tedros, the DG of the World Health Organization. He is focusing, in his speech, he focused on 4 key elements. The first one is political will. The governments have to take the responsibility and go that way. The second is, of course, implementation in countries, because this is the discussion at the global level, but this has to be done in countries and by the countries. The third one is scientific evidence, because there is already a body of evidence of what can be done and what can work, what cannot work also on implementing the One Health approach. And the fourth one is collaboration. Next one. So what is the significance of all this global talking, blah, 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 about One Health? What is the significance for the countries? This has to be translated into the country context. And as I mentioned, the political will, the government is critical. The government is the driving force has to take responsibility and to coordinate the different sectors. This is very important. I think the work done by the universities in Somalia is commendable. But I was really happy to see many ministers here, because at the end of the day, they have the responsibility, and what the university can do is to provide the evidence, to advise, to inform. But then there are decisions that have to be taken by the government. Also including the legal framework that Serge was mentioning in the previous presentation. There is a need to arrive to some deliberation by the parliament from the legal side of the government. And so that's why it's so important. And then the implementation guidance identifies these three pathways. One is related to governance, the other one is related to institutional development, and this also needs coordination across different sectors, and the other one is related to data. So in that guidance, there is it's good to inform actions in the country, but then the steps have to be adapted to the country context. It cannot be the same everywhere. Next. So, let's talk about Somalia now. I have a little bit the impression that this morning we talked about many things, but all of them quite high level. What is the meaning of One Health approach in Somalia? Somalia has already taken a commitment to proceed to universal health coverage. This is one of the targets of the Sustainable Development Goals. And this is a strong political commitment. There are some key elements that are the essential package of health services and the primary healthcare approach. And about that I would like to say something more later. Somalia has also taken a very strong actions in health security on the wave of the COVID-19 pandemic. The pandemic hit Somalia, especially on the economic and social side, but gave the opportunity to develop some of the systems that are needed for health security, and are the same systems that are needed for the One Health approach. To give just a couple of examples, now Somalia has public health laboratories, well equipped and with people trained all over the country, with quite a good capacity that can be used. And there is also a surveillance system, disease surveillance system reaching everywhere. This is because this is what we are facing, and especially the ones among you that do clinical practice in the country. Some anthropozoonosis. I mentioned there toxoplasmosis and leishmaniasis. Leishmaniasis is not is not a high burden of disease, but is something really, really bad. I have seen children dying of leishmaniasis because the drugs used to treat the disease are not effective, because they are used for animals. And you know, this is a case as an example for the legislation. In other countries in the world, there is a legislation that prohibits to use antibiotics in dogs, for example, that have leishmaniasis. Those antibiotics that have to be used in human. So there is a segregation of the use of drugs. And that has brought some effect because it's more, those drugs remained more effective for humans. But in Somalia, the same drugs are used for animals and humans. So antimicrobial resistance is increasing, is becoming a huge problem. Now we can talk about dogs, but I understand that in Somalia many farmers or the herders, they use doxycycline, tetracycline for their animals. And this is totally unregulated. And you know, tetracyclines are among the antibiotics broadly used also in human. They are cheap, effective, but we are inactivating an important weapon against infectious diseases. So this is a good example to think what should happen related to antimicrobial resistance. Other examples are vector-borne diseases, and as we all know, they depend very much on the environment, on the water reservoir, the mosquitoes breeding sites, etc. The vector-borne diseases. Water-borne diseases, cholera and typhus, we all know, and cholera seems to be endemic in Somalia. To me, as a medical doctor, this is unacceptable to have cholera endemic. I can understand that there is an epidemic, but then we should be able to stop it. And this is a problem of relationship with the environment. And also the environmental threat that we very often we don't think about in the realm of One Health, but is also important, snake bite, for example. The problem of addressing these issues, let's think only about human health. There is a problem, and we know the health system in Somalia has to be improved. One of the main problems is fragmentation. There are projects and programs, usually vertical, that address a certain number of diseases or a certain field of health. We have the program for TB, HIV, and malaria. We have the EPI, which addresses immunization. But the role of the government there is to respond to the need of the people across whatever needs, not by project. There is no project for leishmaniasis. There is no project for toxoplasmosis or for typhus or for snake bite. But that is a need of the population. So, looking at the One Health approach, that can really be not only build on what exists, but also be the advantage, the common ground to address the health of the people, the needs of the people, that are not only human health, but if my camels are sick, or if there is only the rumor of a Rift Valley fever, I cannot send the camel meat to Saudi Arabia, is a disaster. So the needs are many, not only related to health. So I would like to put on the table the opportunity to use the One Health approach as the common ground to address the needs of the people in the country. Health need for human, animal, and environmental health. Next one. Now, why I put the title of this presentation as the One Health for Universal Health Coverage and Health Security. This is the approach promoted not only by WHO, this is a very old Think Health for All in 1978, Alma Ata, the first conference on primary health care. This commitment has been renewed in 2018. in Astana, and there was recently, last year, a conference to take stock of where we are. What is primary healthcare? Primary healthcare is not only healthcare at the lowest level, low cost, and for poor people. Primary healthcare is what also the rich countries are trying to implement now after COVID, because it means having services available as close as possible to the people and responding to the real needs. And it has three dimensions. One is delivering services that respond to the need of the people. The second is the community ownership, not engagement only, ownership. And when I talk about community, I'm not thinking about the rural community down there that needs health services. Also the ministry is a community, the university is a community. And this program has to be owned by those communities. They have to get responsibility, take responsibility for that. And the other dimension is multisectorality, because there is a recognition that no disease can be treated if there is no multi-sectoral approach. With the education, as we heard this morning, health should be in the education program from the primary school, and with the environment. Now, there is an increasing burden of non-communicable diseases in Somalia. I'm talking about chronic, like diabetes, metabolic and cardiovascular diseases. And they are very much linked to the lifestyle, to the determinants of health. So, multisectorality is also critical. And if you look at it, it's the same that we need for One Health. We need to respond to the need of the people, we need multi-sectoral approach, and we need responsibility of the community and the government at every level. Next one. This is very much institutional for me because this is the general program of work of WHO. Well, now we are going to the 14th general program of work, and the approach is going to be similar but more developed. But the three essential pillars are the promotion of health, protection of health, and the healthy lives, healthy environment. And primary health care is the backbone for them. Next slide, please. Now, I don't want to stay long on that because I think the people who are working in the health services, they already know what it is, but something visual. Let's go to the next slide. So the primary health care, the people come to the facility, to me as a doctor, to you. They are not mentioning a diagnosis or a disease. They don't come with this kind of needs. They don't say, I need a diagnosis for pneumonia. Next slide. Again. So what they need is the symptom. What they need, what they mention. Everybody's coughing. All these 3 children are coughing. The causes can be different. But this is how they come. This is how the people access the facility. So responding to those needs is critical, and this is the main concept of primary health care. And it's powerful. It's a powerful concept, responding to the needs of the people, because that increases the trust of the population to the facility. You know much better than me that one of the obstacles in Somalia is that people don't trust the public facilities, because the quality is low, there is no medicine, the staff is there or is not there, we don't know. But the private cannot reach everybody, and we are leaving behind the people that are not able to pay. So this is the huge value of the primary healthcare approach, to respond to the people's needs and build trust. And this, let me tell you, is the approach that is needed also for the One Health. Let's go to the next slide now. And then we are almost over, but I don't know if Serge is still online. This colleague, he presented a very complicated governance system for One Health. Now, I've been in Somalia in this position for 3 years. I've been in many other countries, and I was in Somalia when I was a real doctor, when I was treating people, a physician at that time. From my point of view, we don't need to build a new structure. One of the problems is that for everything that comes from outside, we try to build a new project with a new governance structure, new steering committee, new everything. And this is very expensive. And at the end, it absorbs all the possible resources that have to go to service delivery. You know, there is a very much emphasis on One Health now in many different funding streams. Just to mention a few. The pandemic fund, there is this big fund from the World Bank, and Somalia applied last year. Unfortunately, the proposal was not successful, but was a very good proposal. And the country is applying again this year, the most probably will get it. The core activities of this proposal are One Health, because to protect the country from a pandemic, we have to have a One Health approach. So this is already a direction where there are resources, human resources, financial resources, and technical resources. Also, the interest of the international community in improving the essential package of health services, implementing the essential package of health services. Also, that one has a primary healthcare approach and can link to One Health. The big effort to build the surveillance system. Surveillance is surveillance. Depends on the indicators you put there. So if you want to add an indicator in addition to what is already there for unusual event, diseases, mortality, can serve also the approach of One Health. So my professional and also personal strong advice is let's look what is already there and build on it. Don't construct something new that is going to be very expensive on the top and not reaching people at the bottom anyway. And there is a responsibility of the Ministry of Health, because of course it's multi-sectoral, but we are talking about One Health, this health. So the Ministry of Health has the leadership and has a huge responsibility of doing this. And needs the information and the support of the academia and the partners. And WHO is here to support the informing, advising, technical tools, etc., together with other agencies. So what is needed? Horizontal collaboration across sector. Vertical collaboration, I intend by vertical, from the top, from the big global level, blah, 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 that we know about, going down to the practical things, how I can separate the drugs for leishmaniasis for the dog and for the child. Political leadership, of course, institutional coordination, and the role of coordination is critical, technical capacities, and those can be built, and there are already a lot in the country. Scientific evidence is what I understand tomorrow, in the agenda of tomorrow, there will be a lot of abstracts that are already giving quite a good ground, growing evidence for One Health. And the financial resources. In my view, the money is never a problem. If something has a strong case, the money will be available. So I think the One Health can be done in Somalia and must be done. There is no other way to protect the people and to protect the economic development and to protect the environment going forward. Next one. So this is, I put here a picture of olive trees. You know why? Because I know very well what happens on the human health. Very little, quite little on the animal health, and I know nothing about the plant health. But this is something that is hitting my community. I'm from the south of Italy, but this is common to all the Mediterranean area. You know, olive oil produced by olive tree is something very precious. And some years ago, there was a disease coming to our area called Xylella and destroyed huge cultivation of olive trees, and that was a big disaster. So also in that area, they started thinking about the One Health, because that was related to the health of the people, the economy of the area, and let me say also the mental health, because for me, this tree, it has more than 100 years. It's like a grandfather. Cannot die from disease. So thank you very much for listening.
We can think like 2 questions for Marina. Marina, if anyone has a question, you can. You have a question? Okay.
Assalamu alaikum. Good afternoon. My name is Dr. Bashir Garba. I work with Seaman University. I'm a public health scientist. Marina, thank you very much for that insightful presentation. I take interest in one aspect of your presentation, and I would like if you can maybe provide some clarification with respect to building lab capacity to conduct investigation. You acknowledged that the country has done a lot by equipping its government labs. I don't know if there is any plan to extend that capacity to some research institutions, because like we know, many of these public institutions, public research labs, are not readily accessible to scientists in the academia. Are you planning to have some form of decentralization of these labs? Thank you.
Thank you for the question. So what happened in the past, let's say 3 years, was that the country needed to make diagnosis for COVID. So there were PCR machines, microscope, ELISA, and then PCR machines brought to the country in public health laboratories. The National Reference Laboratory in Mogadishu, but there are public health laboratories in all the capitals of the states. And some of, I think 3 of them, they also have the genomic sequencing capacity. So this is a huge technical capacity that is there. And let me say, I have the impression it's not used enough now. If I have to respond directly to your question, as WHO, we don't have any plan to support laboratories in the universities at the moment. There is no such a plan. However, if there is an interest, we can start by using better the laboratories that are there. Because recently, also our new WR, she was asking question why we talk about suspect diphtheria. We have to do the test for diphtheria. We have plenty of capacity here. If the reagents are not there, we can make the reagents. And you know what, in my team, is the UHC team, we are trying to develop a very practical plan for strengthen the network of laboratories and also have a better use. The problem is, they should have, I'm going to the very practical thing, they should have the reagent for diphtheria, for whooping cough, for these kind of things, because they are happening. The problem is that the supplies expire, so it can be a waste of money. So what we are putting down as a suggestion is to have the minimal supply, and with a protocol that maybe 6 months or 4 months before expiring, if they are not used, can be used for research. So in this way, they are not wasted. So this is still on paper. We are working on it. And in order to do that, we need to involve the universities. We need to involve also the private hospital. I've seen that many colleagues working in the private sector, they are very active on these things. And it's a win-win, you know, because you can inform, you can also help the public sector in developing knowledge that that additional capacity to do research when I have 200 tests for diphtheria that I didn't use. These laboratories also already have the serobanks, so there is plenty of material for research. Let's put it on the table and discuss. I'm happy to meet again and discuss about some specific things related to the laboratories.